and welcome to this afternoon's hormonal contraception overview. Okay, so I am part of the Next Plan Training Support Programme. So obviously this afternoon's session isn't just about implants, but primarily my role is within the training of implants, or the insertion and training programme. We are funded by Organon. All nurses are employed by Bionicle and provide service on behalf of Organon. So the agenda for today is UK MEC, recent faculty guidance, hormonal contraception, intrauterine subdermal contraception, problematic bleeding, and emergency contraception. Please feel free to unmute at any point or put something into the group chat. I'm not sure if I'll be able to see the chat until the end of the session. There's not lots of people on, so if you really do want to ask a question, please feel free just to unmute at any point, and hopefully we can deal with the question as and when they arise. So UK MEC, so I'm assuming you're all very familiar with the UK MEC. The most recent version is the 2016 edition. You can print it off, you can download it, you can get it from the faculty, and it is just a very useful tool for enabling practitioners to be able to identify which is the safest and most appropriate option for women in terms of contraception. I think we know that some methods in particular have more risk factors. So in terms of the COC, we know there's a lot more 3s and 4s attached to it, whereas some of the progestogens that we're dealing with have more 1s and 2s. So I think it all does depend on women when they present, what type of history they present with as to what we can work with in terms of contraception. But this is our best tool. And in terms of anybody that presents and they want a specific method, and we know actually they can't have that for various reasons, UK MEC is a good tool to share with them as well. So we can actually say, well, you know what, you're presenting with migraine with aura, you've got other risk factors, and you can show them that the score maybe comes out at a 3 or a 4, which is just not ideal, and it's their safety more than anything else. So faculty guidance that we've seen within the last couple of years, contraception after pregnancy, I'm just going to list them all there. So contraception after pregnancy from January 2017, and then more recently amended in October 20, is really just pushing for women to be offered contraception much earlier, even at the point where they're discussing contraception throughout their pregnancy. So, once they've had this baby, it doesn't come as a shock to them that they're very fertile quite quickly afterwards. So off license, we can offer contraception before day 21. Not with all women, because it isn't always applicable, and some women we may see more vulnerable. So we definitely want to target those ladies and make sure that post-delivery, if the vulnerability is, previous terminations, previous unwanted pregnancies, or there's just something else going on where we know that the contraception maybe isn't a priority, we need to maybe have those conversations much sooner and initiate contraception even before day 21. Day 21 is the optimum time, because we know if we initiate it then, it's immediately effective. After day 21, it's absolutely fine to consider contraception. What we may need to do is consider adding in condoms or abstinence until that method actually kicks in and starts to work. Drug interactions from November 17, and obviously more recently it's been updated. And I think the big thing with the drug interactions is in general practice in particular, we can see what women are taking, we know what the medication they're on, but we're seeing a lot more women now accessing medications from over the counter or from the internet. We need to be mindful of that when doing our consultations. So we just need to double check that we're looking for the enzyme inducers, the likes of your St. John's wort, your modafinil, your topiramate, all the things that may be given for another reason, and we're not actually linking it into contraception. You've got your Medscape that you can use to be able to identify if it's a compatibility issue, or obviously your BNF. And the drug interaction information from the faculty is very useful. It's very lengthy, but all of the medications are listed there. It just does help us when we're looking at what is the best method. And if they're on something, in particular modafinil, we need to be considering offering something that's more suitable. So the range of drug interactions that we have, the most useful, the most applicable contraception would be the IUD, the IUS, or the depot, because they don't tend to have any issues with some of the enzyme-inducing medication that is available to us. Contraception for women over 40. I think we see and we hear lots of women who still think that they get to a certain age and the fertility has really declined. But in actual fact, we need to keep going up till the age of 55. We don't see that many women in their 50s who present with an unplanned pregnancy, but there is a certain, there's a small amount of women out there who still will be ovulating, and we need to consider this. It's very difficult to establish if somebody's gone through the menopause, so the expectation is that we just keep going, especially with, well, obviously the progestogen methods until the age of 55. Emergency contraception, we have the 3 methods in this country. We have the IUD, we have Ella1, and we have Lebanel. which we'll talk about at the end of the presentation. Combined hormonal contraception. So again, this has been fairly recently changed. I think some real breakthroughs with combined hormonal contraception, in the sense that it doesn't have to be stop-start, it can be taken continuously. Women can have a lot more control with the combined methods now, and this applies to the vaginal ring and the patch as well. And I think sometimes we think about the COC as just being a pill. We have the alternatives there, as the vaginal ring and the patch as well. And then the progesterone-only implant, most recently updated in February 21, and we'll discuss that throughout the presentation as well. So the next slides will allow discussion around oral, intrauterine and subdermal contraception. We'll look at failure rates, counselling and suitability, administration and fitting, and bleeding patterns. So combined oral contraception. So I've already mentioned we've got the pill, we have the vaginal ring, and we have the patch as well. In the UK Met, there was an actually specific section that alludes to the ring and the patch. So the theory is, if somebody's eligible for a COC, the likelihood is they'll be eligible for the vaginal ring and the patch as well. In failure rate, so perfect use would be a 0.3% failure rate, which, you know, sounds quite good, but in actual fact, typical use is 9%. So we know that lots of women actually don't take the pill correctly, they forget how to use it, and then obviously then it becomes the potential there for an unplanned pregnancy. Sorry, my phone's just ran there, wasn't meant to. Just bear with me. So a very user-dependent method, and I think when you're counselling women, it is about establishing, is this the best method for you? Have you got that routine? Will you remember to take it? UK Met criteria for use, so we know this is the one that does carry a lot more 3s and 4s, and we need to be very mindful of that in our consultation. I think in a lot of the clinics that I'm seeing, when you're doing your assessment, there's a lot more questions to ask when you're doing your initiation of a COC. We need to establish, you know, medical history for the particular patient, and also look at family history as well. And I think, you know, we have to really be mindful of this. Some people will not always tell us what we want, the right answer to the questions, because they actually know that if they've got migraine with aura, for example, we don't really want to give them this method, but they're so established on methods sometimes, they know that we might have to withdraw it. So I think, you know, do the best, use your assessment tool, whether it be System 1, whether you've got the Ardens built in as well, but just be mindful, marry it up with the UK Met and just double check that they're eligible and they're sticking with the 1s and 2s. History taking and suitability, so this boils down again to our work counselling. I think it's excellent now, and I think since lockdown we have been able to obviously do consultations over the telephone. We don't have to see women as frequently within our clinic, but what we have to remember is if somebody's had up to a year, clinic can happen within that year, so we need to be mindful of that and remind women, yeah, you can have your year's supply, but, you know, if your medication changes, you know, if there's any concerns with blood pressure, migraine, smoking, obesity, we need to come back in and obviously check that with them. And I think that's the difficulty with some of these, you know, methods that we can give a little bit more long term. Things change very rapidly, and I think we saw a lot of this within the lockdown, women gaining weight and we weren't maybe aware of it, or mental health changes. So I think we need to just check in now and again, even if we know it's great, we can give up to a year's supply or 6 months, just put the onus back on the patient to check in if there's any concerns that they may have. Age range, so the age range for a COC, the upper age limit would be 50. The lower age limit, really, there isn't one as such, because if you identify somebody as being sexually active and they need contraception and then they fit the criteria, they can be initiated on a COC from a very young age. It may be that with that comes a little bit of safeguarding, which may open a can of worms, but in terms of your contraception, in terms of, sorry, somebody else is ringing me now. So yeah, age range, it may be that you just need to consider safeguarding. But if somebody is, you know, a victim of exploitation or there's some abuse going on, the last thing they want is to have an unplanned pregnancy as well. I'm so sorry, I don't know what that noise is. Compliance with daily dosing. So we do know this is a particular method that is user dependent. In part of our counselling, we really need to make them aware that this is something that they have to do. It's daily dosing. If they miss a pill, they need to have the guidance there. And I think, again, it just boils down to people's lifestyle. If they're very busy, it may be that they can't remember to take it. So is it really the best method for them? And I think with the newer way of taking pills, with the long-term sort of the 3-month tricycling or the long-term use, we can get away from that concern around people forgetting when to restart it when they've had their week off. And that's something we'll talk about as well. Missed pill information, so I think there's a lot available to women now. There's apps they can put on their phone. Obviously, when they start on a pill, they get the information within the leaflets. So I think it is all there for them, but I think it's just very important that they know any concerns, maybe ring and access for emergency contraception. Clinical guidance, week starting. So this is something that it was very many years before we could actually do this and be competent in doing it. And I think we always used to want women to be either on their period or be very, very sure that there's no risk of pregnancy. But even more so now, with access to appointments being quite limited, we can quick start contraception, we can quick start the COC, providing you are reasonably sure there is no risk of a pregnancy. So quick start them and maybe do a pregnancy test in 3 weeks if you feel there's the indication to do so. But it just means you've captured somebody there and then. And if they are in early pregnancy and it is too soon to be able to identify that, having this hormone on board, the guidance just suggests there's no risk to the fetus. So I think we just have to make sure that if you're quick starting, that the woman goes away and knows to do a pregnancy test. You don't need to see them back in practice. You can put that back onto them as long as they're aware that they need to do that follow-up pregnancy test in 3 weeks since their last episode of unprotected sex. Tailored regimes, we're going to go on to that next. So we've got the different regimes for taking pills. So historically, we've always had the 21/7. Which is what everybody seemed to like and prefer. But this is where we would see a lot of women who would get confused with that 7-day interval and maybe forget that they'd run out of pills and then realise that when it was day 7, they didn't have any pills and they couldn't get them that day. So they would extend their pill-free interval, which then potentially could mean they would ovulate. So then we looked at the 21/4. So 21 active pills and a 4-day break. And the reason for this is one of the reasons, is if somebody has the 4-day break and hasn't got the pills or they forget to take them, by the time they do, they hopefully will be within the 7 days. So again, it won't allow them to ovulate. So it's just another way of taking it. There's the extended or tricycling, which is the 3 cycles back to back, followed by, again, either the 7-day or the 4-day interval, whichever the woman chooses, or the flexible regime, which is continuous, but it has to be for at least 21 days. And once they've had 21 days of active pills, they then would just wait for their body to tell them when to have a break. So what would normally happen is for several months, they don't have any bleeding, then all of a sudden they'll get a couple of days or 3 or 4 days of consecutive bleeding, and that's their body telling them then to have their break, whether it be a 4-day or a 7-day. And I think it's great that we have these options, but still a lot of the literature and a lot of the leaflets that come with these methods don't always promote or discuss this. So it is off license, but I think if you've got women brand new to taking COC, it's give them the options and work out which is going to be the best for them. If somebody's already very well established and likes the 21/7, why upset the apple cart? Let them stay on it. But if you find that people are struggling with the break, maybe reduce it to 4 days so they don't then potentially extend it and risk ovulation. POP, so failure rate, perfect use and typical use, is the same as a COC because it is user dependent, so it's no different in a sense. UK Met criteria for use, so we know with progestogens there is a lot less to worry about. Obviously we still need to do our thorough assessment, but what we have to remember is there's less number 3s and 4s in the UK Met, but also with the POP becomes that propensity for some unpredictable random bleeding. COCs have a much better reputation for bringing about a good cycle control. We know with progestogens you don't always achieve this, so again it's just making sure when you're doing your counselling, women are aware of this. Some people swap from one to another and they're not made aware that this particular method might change their bleeding pattern. And something else that occasionally crops up with the POP is somebody's being changed from a COC, perhaps because their BMI's gone a little bit raised, and then swapped to the POP and they haven't been told that they don't need that pill-free interval. So occasionally you see women on a POP who are still having their week off, which really is a massive risk to an unwanted pregnancy. So it's just making sure that you've covered all of that. Age range, so lower age range, same as I've mentioned with the COC. If you've identified somebody very young and they're Fraser competent, you can start them, 13, 14. It's not ideal, but it will prevent that unplanned pregnancy if they've got a lot of other issues going on. And then with your progestogen methods, up to the age of 55. History taking and suitability. So this is the one where we don't have as many things to consider when we're doing our first assessment for a POP, and things can change. So again, making sure that every time you really prescribe it, even if you're not seeing that lady face to face. It is, you know, opportunistically, we need to be looking at things like blood pressures, heights and weights, BMIs, just so we've got it recorded, because often it's quite easy to initiate in some women, so we do all the basics and fail to consider things like their blood pressure, their height, their weight. And when they do come back and they have a problem, we haven't got a baseline. So obviously a POP is one of the safest, we know that, but it's also good to have just the baseline. So if they do come back and, for example, say they've gained weight, you know, which we know all of these methods shouldn't put weight on women, but we do see women who will associate weight gain with their contraception, but we don't have the baseline. We have nothing to discuss. We have no bargaining tool to say, actually, you haven't gained any weight. So just where possible, opportunistically try and get those recordings into their notes. Timing for daily dosing and missed pill information. So again, you've got your desogestrel pills, which are the first line now for POP. There aren't many of the traditional older style POPs available to us, but there are some. So it's just making sure you have that awareness between desogestrel, which is very effective, 97% effective at stopping ovulation, whereas our other POPs don't have that that added bonus. So it's knowing that we have to consider your desogestrel has a 12-hour window, where the older style POPs are still 3 hours. Weight-wise, so we know with this method, there's no upper weight limit at which we need to be concerned. COC, however, as the BMI approaches 35, we would have to bring them off that particular method. POP is different. Anecdotally, some women who are a little bit overweight may report unpredictable bleeding. Same with people who are on a LARC method. So there is anecdotally some recommendation to double up on the POP. It's off license. There's not a lot around, you know, actually doing that and supporting it, but we do see in clinical practice that sometimes just those 2 POPs is enough to be able to combat the bleeding that's obviously undesirable. Bridging, so if somebody presents today, for example, and they want a LARC, they want an implant, they want a coil, but logistically you can't do it, it's good to get them on a POP. So it's very quick to do so, and it just means when they do come back for their method, they're good to go, and you know there's minimal risk of pregnancy. So then we've got our depot, so failure rate 0.2%, typical use 6% failure rate. This one is considered a little bit more of a lark. You know, it's got the 12 weeks and 5 days by the manufacturer's guidance, but supported by the faculty as 14 weeks. So it is a bit more long acting, but that 14 weeks comes around very quickly, and some people just don't manage to get booked in time to have their next dose. So this is where we get this failure rate. So I think, you know, it's making sure women are aware of the next appointment. We would never give them the 14-week. We try to give them 12 weeks, so they've got a little bit of leeway there. And then it's gluteus or deltoid muscle for the insertion. This is the IM method. We do know with this particular method that there is that association with weight gain. This is the one method we know, and it's not that it just automatically brings about weight gain, it's the fact it works on appetite. So we'll see people with this method perhaps already a little bit overweight, so therefore have an increased appetite. We'll find that increases even more with this method. So as you're counselling, make sure you've done the weight at the first appointment, so we know the comparisons there when they come back. Age range, under 18s is with caution. This is quite a huge dose of hormone that you're giving in one go. And we know that it depletes a lot of the free-flowing estrogen that's available to the body, which again can impact hormones. So if you've got women under 18 and they're coming and it's the only method they want, as long as you've explored all the other methods and they're aware of the minimal risk to bone density, that's absolutely fine. So the age range is under 18s with caution. Up to 50s, obviously, providing they meet the criteria and they have no other risk factors for bones. And again, up to 55, if you've got very fit ladies who have no other predisposing factors that would affect the bone density. And I think this is a method that once somebody's established on it, because of the amenorrhea, because it's discreet, because it's a little bit more long acting, women tend to get very fixed on it and don't always want to change. But the reasons obviously would be if they have any bone problems, or if they are gaining too much weight, we have to consider, is this the right method for them? And then we have Cyana, which is bioequivalent, so pretty much does the same as our depot. This is the subcutaneous version, and this has license for self-administration. This is something that we're seeing a lot more used now in general practice and in sexual health clinics, because once somebody's established on it, they can have up to a year's supply, will not need to come back into clinical practice to be seen. So if somebody's very happy to self-administer and they're confident to do so, that's up to a year of them not having to come in into practice for appointments. Just exactly the same as Depo. The age range is the same. UK MEC is the same. The only difference is it's subcutaneous, and it's, for most women, it's administered by themselves. So this is just the MHRA advice. In adolescents, Depo may be used as first-line contraception, as I've already mentioned. In women of all ages, re-evaluation of risks versus benefits should be carried out every 2 years. Now, I think if you're somebody that actively is giving Depo on a regular basis, you'll be doing that assessment every time you see them. We're not going to wait 2 years to suddenly then address the bones and the weight and other health lifestyle factors. So I think it is something that 2 years seems a bit, you wouldn't wait that long. And I think we're very good at knowing each time we see these women that we check all of the things that would either, you know, make us continue with the Depo for them or advise them to look at an alternative method. Significant risk factors for osteoporosis, and this is obviously other things to consider in your consultation: alcohol abuse, chronic use of drugs that can reduce bone mass, low body mass index, so women who've got eating disorders, previous low trauma fracture, or family history of osteoporosis. So this is just your information regarding intrauterine and subdermal contraception letters of competence. Can't see who's on the call today, and I don't know if we've got any coil fitters or any implant fitters, but as an implant trainer, I'm more than happy to answer questions on the programme for the implant training. And these are the two modules that as the coils you would do 18. It used to be 18 and 17. The implant one is now 14. The guidance has changed from the faculty, from the DFSRH regarding that. So you would do the online exam, which is the OTA, and then that allows you to open up the pathway to do your coil training or your implant training. The OTA is 60 questions in an hour, or multi-choice. So if anybody does have a particular interest in pursuing this and exploring the training process, you can always email me or ask questions at any point. Intrauterine contraception for perfect use, you can see there the IUS and the IUD. Nothing is 100%. We know these methods are very effective, and we know with our IUS, which is the hormonal method, we've got the hormone in there as well, which again will add extra benefit to the contraception. Then you've got your IUD, which is the copper coil, which is hormone free, and it's really that the copper, the sperm doesn't like the copper, it's simplistically, so that's how it works. UK MEC, so again, we've got to consider when we're counselling. And I think when you're counselling women for this particular method, there are lots of myths and misconceptions around it. You know, if you haven't had children, you can't have this method, which is again a myth. You know, if somebody's already expelled an IUS, it shouldn't put them off maybe trying another one. There's lots of different versions of IUSs and IUDs available to women, and sometimes it's just a particular device, it doesn't suit some women, so maybe consider looking at others to see if it would adhere better when sited in the uterus. Age range, so upper age limit. We know for women, we've already mentioned that women need contraception up to the age of 55. So it does depend on what age they've had it fitted. So it's making sure you're very familiar with the faculty guidance there. Lower age limit, I think we're seeing a lot of younger women who are expressing an interest, more so in the IUD. I think there's lots of research out there, and people do a lot of their own research to decide which is the best method for them. And we're seeing a lot of women who are actually wanting no hormones at all, and they're aware with an IE they will still get a bleed. It may be a little bit heavier, but for them, for where they are in their life, they just don't want hormones at this present time. Counselling, overall risk of an ectopic pregnancy is reduced with use of an IUD when compared to women not using contraception, and that's another one of those little myths. People panic and think that it's going to increase their risk of an ectopic, but actually there's no change there. Expulsion, so it's most riskiest time for an expulsion is post-insertion. So obviously when somebody first has one fitted, and they may have some bleeding that is associated with that, it may expel while the bleeding. So very important that women check their threads, they know what they're feeling for, they know what it looks like, because often women don't know what their coil looks like. So they might not even realise that whatever they're seeing, you know, is part of the coil. So making sure that they know how to feel for it, making sure that when they're feeling for it, what they're feeling for is the threads. If they're feeling anything more than that, that potentially might mean that coil is already on its way out. So for them to be encouraged to access GP or sexual health if they've got any concerns. And in the interim, if they can't find their threads, they're really concerned, encourage another method of contraception until somebody can establish if it's still in situ or not. Postnatally, so we know now postnatally a coil can be fitted, or an IUS IUD can be fitted within the first 48 hours post-delivery. And this is something that we're seeing a little bit more frequently, and it is just the optimum time to fit it. Somebody's just had a baby, they maybe not consider contraception when they get home. Life's very hectic, so why not get it inserted straight away after the delivery? If it's not inserted within the first 48 hours, due to the way everything sort of shrinks back down and the anatomy and physiology changes or reverts back to normal, if it's not within the first 48 hours, then they would have to wait 4 weeks for that insertion. And they're just your different types of IUS that are available to women. So you've got Kylena, Mirena, Levocert, and J-Des. So Kylena is the 19.5 milligram device, which is licensed for 5 years, only licensed for contraception. Mirena is the slightly bigger dose and slightly bigger device as well, licensed for 5 years and also licensed for endometrial protection. Levocert is bioequivalent to Mirena, and then your J-Des is the baby of the bunch. It's slightly smaller, and I think when it was first launched, the expectation was it would be suitable for nullets because it's a little bit smaller and it's 3 years, and maybe that's their preferred choice. But in actual fact, you know, as a fitter and looking at women, sometimes young people have no issues having the Mirena fitted. So I think if you're struggling and you need something a little bit smaller, you may revert to the smaller method, smaller device. But I think every woman will be different, and some will go in very easily, some more difficult. And then subdermal implant, so perfect use 0.05%, typical use is the same. This is a 3-year method, which is classified as a fit and forget. So once it's in, it's not user dependent. The only time it becomes user dependent really is when it expires and the patient needs to have it changed within the right time frame. During lockdown, the use of Nexplanon was extended to 4 years, with a caveat that the efficacy couldn't be guaranteed, obviously the same as 1 to 3 years, but there was some assurances that actually, you know, women were going to be okay. But if you were in doubt, you could bridge with a POP as well. Shortly after that statement was launched and the world sort of got back to normal a little bit, it was acknowledged that actually is a 3-year method. It's licensed for 3 years, so where possible, we need to get back to making sure that women have it removed and replaced within the 3 years if they want to continue with this method. Age range. The actual licensing age for Nexplanon is 18 to 40, but we do know that off license it gets fitted in lots of under 18-year-olds and lots of people over the age of 40. Same again with the age, it would be the cutoff would be 55. And it's just, you know, I think sometimes it flags up on some of the systems that you're working off license if you try and fit it in somebody outside of those age ranges, but it's very supported by the faculty that it can be fitted. UK MEC, again, it's a progestogen. There's not many reasons why we wouldn't be able to fit it. And this is the one thing with a fit and forget. Somebody may be very eligible at year 1. In year 2, something quite significant may happen. So we need to be mindful that when we fit the implant and we give them their user card, that we remind women that if they've got any changes, you know, within their immediate family or with themselves, it may be worth just having that quick phone call just to double check that it hasn't pushed them up to an increased UK MEC score. Time of insertion, so we can fit the implant anytime within the cycle, providing we are reasonably sure there is no risk of pregnancy. Obviously, if it's outside menstruation, it will be condoms for 7 days. Postnatally, it can be fitted off license, but again, if you've got somebody, you know, postnatally or post-termination, it can be fitted straight away. But that's, you know, it's not happening all of the time, but it's there if you've got somebody that you're concerned and you worry that, you know, they're not going to address their contraceptive needs when they get discharged. Position. So over the years, there's been quite a lot of discussion around where do we fit the implant. So the answer is it's 8 to 10 centimeters from the medial epicondyle, and you avoid the bicipital groove or the sulcus. I think sometimes the groove, the sulcus, is sometimes a bit of a mystical being. We can't always find it. We don't always know what it looks like. So the real thing for us is when we're training people, we ask our ladies to make a fist and we push against their fist, and that often is just enough to be able to identify where the groove is. So you all know where the bicep is, so that's what you're looking for. You're looking for the bicep and you're looking for that little groove that sits within there, and that really is the point that we need to avoid in terms of fitting. There's lots of information out there, and I'm more than happy to do updates with people on a one-to-one if anybody has got any major concerns about their fitting or even their removal technique. Palpation, once it's in, it's very important that we feel that the implant is where it should be. We also need to make sure that the lady as well knows where it is, because we know that they can move around a little bit. So it's important that they once a month have a little feel, and if they ever felt it was maybe going a bit deep or it was starting to move too significantly, it would be really important for them to come back in so we could re-evaluate it and look to see if we need to remove it early and replace. And just something about removing early. We used to say with any broken implants that we didn't need to worry too much because they still work, which we know they do. But if an implant is completely snapped in 2 or in 3, when it comes to removing it, it may be very difficult because it started to migrate in very different directions. So if you identify an implant that is perhaps snapped, what you need to do is remove it there and then, or make sure that you remove it as quickly as possible, just on the off chance that it might start to separate and make removal difficult at the end of 3 years, because we don't want to leave people with implants that we can't remove. Counselling women should be informed that the manufacturer states that an early replacement can be considered in heavier women. This is a little bit of a grey area, and it's really difficult when you see women to explain this. So guidance from 2014, I think it was very much around making sure that any woman over 70 kilograms, which is only 11 stone, we had to have that conversation, that actually your implant may not be as effective in that 3rd year. But that's going to really put the fear of God into everybody, and they potentially might not want to go with that method. So I think individual basis, look at your ladies, make sure that they're aware that if they start to gain weight, they maybe need to consider early replacement. But interestingly, that's the manufacturer who say this. The faculty say we don't need to even worry about it. So I think it depends where you're sitting as to how you deal with this. So for me, if somebody presented with, problem, they were concerned that they were overweight, I would look at the bleeding pattern. I'd look at previous fertility, have they fallen pregnant easily in the past, or maybe fallen pregnant on another method of contraception, and just clinical judgment. It's difficult because it isn't a right or wrong answer. But in my experience, women might get to 2.5 years and say, actually, I'm a bit concerned. There's no harm in changing it that early. But anything earlier than that, you just think you're not really getting the value or the benefit of the method. So this is just the importance of where we site the implant. And I think this is the big thing from the last couple of years, subdermal, and just making sure that you're avoiding the bicipital groove, which is where all the nerve endings are that we really need to stay away from. Problematic bleeding with hormonal contraception. I think all contraception has the ability, the propensity to bring about unpredictable, problematic bleeding, whatever you want to call it. So these really are the steps that we would take, come back over there, in looking at women if they do present with bleeding problems. The main thing is anybody on new contraception, we would always recommend at least persevere for 3 months. It may be that whatever method, it may be that's going to take time and it may settle down. So just consider perseverance. If after 3 months, it's about looking at, is there anything else going on that could be causing this bleeding? Is it definitely the implant, the depot, or the pill? Is there something else going on? So look at, STI risk, chlamydia, gonorrhea. Do we need to consider a pregnancy test? Is it some hormonal bleeding that we've missed? Have they had their cervical screening? Are they perhaps on some new medication, which is an enzyme inducer? So, for example, somebody may have bought some modafinil from the internet, which we know is a narcolepsy medication, which is very prominent within student populations. So students are buying off the internet to keep themselves awake, and it's an enzyme inducer. So it's knocking off all their contraception. So as much as they may not be very forthcoming in telling us that they're on these medications, yes, they're prescription only, but they've acquired them via a different route. Make sure you ask, is there any other medication that you're on, whether it be internet, over the counter, from a friend. We know people sometimes borrow medication off friends if they think it might work. So just double check there's none of those things that could be contributing to the bleeding. In your over 45s, consider referral. Is there something that we're missing? Do we need to look at the cervix more, have some more investigations? And then emergency contraception, so copper intrauterine copper device, which we know is the first line, it's gold standard. Then our progestin receptor modulator, which is UPA. And then you've got your progestin-only oral pill, which is your 11L. Copper coil, we know, is the most effective. Progestin receptor modulator, UPA, is the emergency contraception that can be given up to 5 days after unprotected sex. And then you've got your 11L, which can be given up to 3 days, 72 hours after unprotected sex. I think this copper IUD isn't for everybody, but as part of your counselling, when you see women for emergency contraception, it's very important that you communicate to them that this is the most effective. we know the other two, post-ovulation, UPA and 11L, are probably more of a placebo and aren't going to work if ovulation's already taken place. So these are just your points of consideration for administration of emergency hormonal contraception. So UPA is more effective if ladies are BMI of 26 or more or weight of 70 kilograms, which, when you think about it, that's a lot of women. 11 stone isn't that heavy, so it's making sure we look at weight when we're looking at emergency contraception. UPA is effective up to the point of ovulation, so even when the LH surge has started to creep up and we know ovulation is going to take place, the LO1 can still stop that from happening. It can halt it there and then, which then will definitely delay it for a couple of days, which means that, you know, it's ideal if ovulation's already occurred. Not many women know where they are in a cycle, but if you can really pinpoint that what their cycle looks like, it may be that it points to this one if you think they're mid-cycle and just about to ovulate. You can't quick start somebody after UPA. UPA is a progestogen receptor. So if you give somebody this today and you start them on a method of contraception that contains hormone, they'll cancel each other out. So you need to consider that. So if somebody is UPA today, but you think actually they need to start a method very quickly, you have to wait 5 days. So I think it's looking at your ladies, identifying, actually, are you very vulnerable? Do we need to get you on something today? Are you prepared to wait 5 days before you have sex again? So I think it's knowing your audience with this one. So I've already mentioned that. And then no hormonal contraception 7 days previously. Again, because it being a receptor, if somebody presents and they've had a couple of missed pills, for example, in the last week, but they've had a few of the pills, it does mean that they've got the progestogen on board already from that method. You start them on UPA, or you give them UPA for an episode of unprotected, the same will happen, cancel each other out. So it's almost pointless giving it. So I think be mindful of that and double check, are you on any other method of hormonal contraception? If not, by all means, you can give them UPA. But if they're on maybe a depot that's coming to an end, implant that's coming to an end, they're all things to consider because they'll cancel each other out. Avoid breastfeeding for a week. So UPA is not compatible with breastfeeding mums. The recommendation is you can give it, but you would advise the lady to express her breast milk for a week and discard it. So I think if you're a mum that's fully committed to breastfeeding, this is probably something that isn't going to be an option for them. And no recommendations with liver enzyme inducers. So if they're on topiramate, modafinil, if they're on any of the epilepsy medications, you wouldn't be able to give the UPA. Then we've got the 11L, less effective in ladies who have a BMI of 26 or more. So the recommendation would be to give a double dose of license. So again, really crucial that you know what their weight is. Less effective during the LH surge. We've already mentioned we know UPA can nip it in the bud even when it started. You can quick start after 11L. So if somebody presents today and they're given 11L, you can start them on any method of contraception the same day, providing you do the follow-up pregnancy test in 3 weeks, because we don't want to miss that pregnancy. Hopefully the 11L has done the job and prevented pregnancy. It's delayed ovulation for a couple of days, at which point the sperm will have died off. Obviously it doesn't always work depending on cycles and sperm life. So I think just make sure that you can double check that they've done a pregnancy test. Consider after missed pills. So we couldn't do it with UPA, but we can do it with LNG. So late pills or a couple of missed pills, they can have LNG and they can start back on their pills the same day. Breastfeeding isn't a problem, so somebody can continue to breastfeed if they have 11L. Enzyme inducers, if they're on enzyme inducers, you would give them a double dose. Okay, and just something about emergency contraception to bear in mind. If you've given an emergency contraception orally, the purpose of that is to delay ovulation for a couple of days. So I think some women assume because they've had one episode of unprotected and they've had that one dose of emergency contraception, that will be suffice for the rest of the month. But actually, if you're only delaying ovulation for a couple of days, the next time they have sex, they are then at risk of getting pregnant from that episode. So when you're giving EC, it's very important that women know to either start there and then on a quick start, if they can, post 11L. If they've gone on to have the UPA, make sure that they know in 5 days they can start their contraception, but remind them that that isn't a forward, which means, you know, next couple of days they could ovulate and get pregnant then. Counselling. Offer informed choice to all women attending, unbiased and non-judgmental. This is something, all areas of when we're in clinics, making sure that women have all access to information, whether it be from us, whether it be verbal or written. And I think that's really helpful. And, women need to have that informed choice. The difficulty is if we're not seeing women in clinics as much, if we do more telephone consultations, sometimes, you need the non-verbal cues. Sometimes, women are saying one thing, but yeah, body language is telling you something else. You can't always pick that up from telephone calls. If you've got any concerns or you just think some of the information doesn't really marry up, get them to come in just so you can double check there's nothing going on that's a little bit untoward. Oops. Consider lifestyle, religion and medical history. Some women, for their religion, cultural reasons, have to have quite scheduled bleeding. So it's making sure that if that's the case, there's certain methods that you probably wouldn't even want to discuss with them. Look at things like needle phobia. Look at who else is involved in their relationships. If it's a young person and their mum's bringing them, is it definitely mum? Making sure there's no coercion going on, no exploitation. And it is just about having the really, robust templates to make sure you address all of those questions and make sure that the sex is consensual and there's no other sort of forcefulness going on there. Adapt your consultation to each patient, which I'm sure I'm very good at, and address the rumours and misconceptions. So I've already mentioned, certain methods do have lots of misconceptions associated with it. So, you hear that people think that the pill will put weight on, a coil is a coil spring, and it's quite big. So I think it's really good to have all the different sort of almost the placebos, the devices available to show people what they look like. Implants, for example, are very tiny, but some people think they're really, large and quite intrusive. So I think it's just making sure that they have access to all of that. So when they're making the decision, they know that they've got the right method for them. Encourage questions. There's nothing worse in a consultation if somebody sits and doesn't say anything because you're just worried that they haven't maybe understood it, or they're just a bit reluctant because they're embarrassed or they're shy. Coming to a sexual health clinic, this is where I am today, isn't for everyone, and I think some people would prefer to be seen in general practice. So I think you've got to remember that sometimes it is uncomfortable addressing some of those questions and finding out what type of sex they're having. And I know that seems, well, why are you asking that if it's just to administer a POP or a COC? But actually asking those questions that might then lead on to information around, well, do we need to consider STI screening and things like that? So I think it's really important to just encourage them to ask whatever and be very open. Consider their age and other risk factors. So, if it's somebody that's approaching menopause, do we need to consider, what method they are on, and do we need to think about the HRT? Something that we can't always offer within our environment, clinical environment, but at least it's raised it with that patient. So making sure that you've had that conversation with them. Take-home messages: women need contraception that is tailored to their needs. Non-contraceptive benefits as well, so making sure that women, if they've got maybe skin problems, if they're on a combined pill, making sure it's the right pill for them. There's lots of information available on some of the websites around the best methods. If somebody wants a pill but they know that they get bloating or they get skin changes, if there's a really good useful tool, and I can send that to anybody, and it just sort of prompts us to maybe tweaking what they're on and maybe offering them an alternative that might benefit their skin or their mood changes, things like that. And it's sort of a decision making tree, I think it's called. It's really useful. For reduced bleeding, I think we have women that want to bleed and women that don't want to bleed. So we have to first of all establish, actually, what do you want from your contraception? Would it bother you if you had unpredictable bleeding? Would it be the end of the world? And that'll help you tailor your assessment as to, and push you down the route as to where they want to be with their contraception. Lark versus non-lark. So some people think a lark is just if you don't want babies in the next couple of years, but actually somebody can present and have a lark. People's lives changes. They don't always, they might plan not to have children, then that might change. So that shouldn't exclude them from being able to have a lark if they're a bit uncertain. Some people might actually say, I don't want to have that in my body for 3 years, 5 years, 10 years. So it's having those conversations as well. Greater choice gives us greater opportunity to practice patient-centred care. And I think, not all of us are coil fitters or implant fitters, not all of us have that information on board. But I think when you're counselling for contraception, even if you're not one of those lark fitters, just having information at leaflets or pointing them in the right direction, the best website they can use, at least then they've got access to all that different information. Getting it right controls fertility, but also has the impact on the woman's quality of life. I think that's it. So that's the resources that we've used today. The faculty obviously is very up to date, and if they do have any new guidance, it's on their page very quickly that it's up to date and there's been some changes. I think we've flown through that. Any questions? You'll all be very quiet. There's one message in the chat maybe. Let's see if I can see that.
Hi, can I just ask, with the double dose POP for people with problematic bleeding?
Yeah.
I don't know when I tend to sort of give it sort of up to 3 months if it's helpful and then drop back down to 1. Is that what you would still do, or do they continue? Is that?
I think that's the best thing to do, because it may be that just gets the endometrium to the point where actually it's going to just shut down and do its job. Do you know what I mean? So I think, yeah, no harm in trying 3 months. Something that I didn't mention actually about problematic bleeding with implants, with coils, is if somebody wants a COC, which obviously anybody problematic bleeding on contraception on a lark would be offered a 3-month supply of COC, very supported by the faculty. It's off licence, but for someone it really does the trick. But with a COC, every time you stop and start it, you're putting your VTE risk right back to the beginning. So there's some schools of thought out there that would say, if you're going to give somebody 3 months of COC for their implant or their coil bleeding, actually, why don't you just let them stay on it? Because if they stop it, have a month off because it's all good, and then start bleeding again and restart it, it's putting their VTE risk right back to the beginning. So it may be that you start them on a 30, if it's successful, drop them down to a 20. Very much trial and error, but just always bear in mind that stopping and starting is increasing the risk factors each time. But I think 3 months for a POP is different because there's no risks associated with stopping and starting the POP. Thank you. I'm not sure if there's any other questions coming. I can't see my chat. No. Anything else? Just have a quick look there. Yeah, I think you're all very quiet. So I will make sure you all get your certificates. And within that, you'll obviously then have access to my email address. So if you do have any questions about anything we've discussed today, or the training for implants, I'm more than happy to have that discussion over email. So thank you for dialing in. I hope you found it useful. See you again. Thank you. Bye. Bye.